Hi, thank you for joining us. My name is Dr. Lance Walsh. I'm a urologist at the Advanced Urology Institute at Titus. Every 2 months, we have a meeting of the Bladder and Prostate Cancer Support Group. Because of COVID, now we're doing these meetings virtually. So we do want you to participate. If you want to make comments, please submit them. If you recall, 2 months ago, September, it was Prostate Cancer Awareness Month, and we discussed at length the diagnosis and screening, treatment, and prevention of prostate cancer. And I just want to have a quick reminder, if you're between the ages of 55 and 70, make sure you see your primary care physician or local urologist to have your PSA checked and a prostate examination. Moving on today, it is November, or Movember, for bladder cancer awareness. We have a guest with us today, Dr. Nayyar Syed, that we will be speaking with in a minute. I wanted to briefly introduce bladder cancer. Bladder cancer is actually not that uncommon. The way we screen for it is by checking a urinalysis, and if you have blood in the urine, defined as 3 or more red blood cells per high-powered field, then you should be seeing a urologist. Also, if you have visible blood in the urine, that could be a sign that there's a problem in your urinary tract. Generally, the problems associated with blood in the urine can be either benign, like stones or infection, or cancer. You can have cancer of the kidney or the bladder or the prostate, and you need additional evaluation with a urologist. Recently, the American Urologic Association published new guidelines on the management of microscopic hematuria, and those take into account age risk factor. So if you have microscopic or gross hematuria, meaning visible blood in the urine, make sure that you see a urologist. So without further ado, I'd like to introduce Nayyar Syed. He's with Texas Oncology. He's been in the community for many years and a very big asset to the community. We welcome him. Thank you, Dr. Syed, for participating today.
Thank you, Dr. Walsh. Thanks for the introduction. So I have been in Mount Pleasant for the last 12 years, and I'm proud to have served my community with medical oncology. I graduated from my training program in 2007. Prior to that, I had worked as a hospitalist on a bone marrow transplant floor. So I've had hematology and oncology exposure, but I then decided to focus on oncology, medical oncology. So today I have a brief presentation for you on bladder cancer, and then you're welcome to ask questions at the end of presentation. So I'll start. Before I go on, I want to introduce our nurse practitioner, Rachel West. She just decided to join Texas Oncology. She's worked with us in the infusion area for about 7 to 8 years, and she pretty much knows most of our patients. And now that she's a nurse practitioner, it's really going to help taking care of patients in town. So I'm looking forward to her officially starting to work, hopefully in a month or two. So bladder cancer, where does it start? Typically, bladder cancer starts on the inner lining cells of the bladder wall, and under the effects of carcinogens that we'll talk about later. It's not seen in younger patients. It's mostly seen in patients who are 55 years of age and older. 9 out of 10 are of that age group. The peak incidence is around 7th decade. It's about the 4th most common cancer among men in the United States, and it's the 8th most common cause of cancer-related death in men in the United States. With any cancer, early detection is the key, and that's your best chance to get to a point of cure. One more point in regards to the bladder cancer statistics. Over the last 35 years, the incidence of bladder cancer has not changed at all. And as we'll talk later, the treatments have improved significantly. And I think the cure rates are going up. I think it's just the beginning of a new era of new forms of therapies, anything outside of chemotherapy, and we'll talk about that briefly. So let's talk about briefly the risk factors for bladder cancer. So smoking, I would say that's the most important risk factor. It accounts for almost 50% of the risk factors for bladder cancer. What is really important is that when someone quits smoking, the risk goes down. And we stress on that even during the treatment. The treatment outcomes are better when someone quits smoking. So it's never too late. But again, if you have just started, let it go. It's expensive. It's damaging to your body, on your lungs, on your heart, and so many cancers. Dementia as a risk factor. Tobacco causes that as well. So other risk factors include some chemicals in the dyes and paint industry, plastic industry, oil industry with petrochemical exposure, among our farmers with exposure to pesticides. You recently saw lymphoma was associated with one of the pesticides. Infections, chronic infections, typically are a risk factor. Chronic stones, anything that's causing chronic inflammation is a risk factor for bladder cancer. In the other parts of the world, there's an infection called schistosomiasis. That's a concern, but not so much in the United States. Now, so radiation therapy and cyclophosphamide, which is a chemotherapy delivered in the past, is a risk factor for bladder cancer. However, it's a very small risk and typically 10 years plus out. So again, it makes it's important to continue to follow up with your physician or if not oncologist, because minimal changes in labs can trigger and make us think of those kind of issues. So not to ignore plain blood count and a chemistry panel, we can detect a lot of things based on those simple labs. Fluid intake is really important. I know it's not stressed upon very much, but if you think of it as that all the toxins that are, once they've gone through the kidneys and they're waiting in the bladder to be expelled out, they're stationed, they're waiting, they're sitting there at the bottom of the bladder. And the exposure of that chemical in the bladder to the inner lining of the bladder is something that can trigger initiation of cancer. So drinking a lot of fluid, especially water, will flush that. And there have been studies that looked into how much fluid or water is taken in and the risk of bladder cancer. And the higher the intake, especially as we get older, the lower the chances. But that is not to ignore. If the person is smoking, you can't just drink water and hope that nothing is going to happen. You've got to look at the bigger picture, but fluid intake is part of that. And there are some rare causes. We're not going to go into those. So as Dr. Walsh mentioned, the symptoms of bladder cancer, signs and symptoms, so blood in urine, difficulty storing urine and maintaining urine stream, sometimes pain on urination, back pain typically confined to one side. That should make us think of something is going on in the kidney or bladder region. Sometimes incomplete evacuation of the bladder is a symptom. Generalized weakness, and that can be, from someone losing blood that is not visible to naked eye, but over time they become anemic, and that can cause weakness, swelling of the feet, bone pain. Bone pain typically would be a manifestation of an advanced cancer. and then labs would help and scans would help. And weight loss, especially unexplained weight loss, is what we worry about as something that makes us think of an advanced cancer. Before treatment, I think I'm going to talk about briefly what does the medical oncologist do once the diagnosis is being made by our urologist. So in this case, Dr. Walsh would have done the biopsy, and the patient comes to us. As you know, I'm a medical oncologist. We deal with chemotherapy, pills, targeted therapies, or immunotherapy. So we start our work with staging, and that most often include a CT scan of chest, abdomen, pelvis, sometimes bone scan, and some more blood testing. And the treatments depend on the stage, and earlier stage bladder cancers, like many other cancers, are treated with surgery, chemotherapy, sometimes radiation. Medical oncologists are typically involved in two scenarios. If the bladder biopsy, in this case Dr. Walsh's sample for us, shows that the bladder wall's muscle was involved, that requires chemotherapy. Studies have shown if the bladder muscle layer is involved, then the risk of cancer progression or recurrence is very high. So you do chemotherapy up front, and then you go on to have surgery, because the outcomes are much better. Chances of cure are much higher. Another thing to mention in terms of cancer's spread and the associated outcomes, typically stage 4 bladder cancer first goes to lymph nodes, and later on to bones and liver, and rare situations it can go to brain and skin. But as long as the cancer is limited to lymph nodes only, the prognosis is really good. About 30 to 40% chance of cure if the cancer is has not spread to anywhere outside of lymph nodes and bladder. So we consider bladder cancer with that kind of presentation as the leukemia of solid tumors, meaning you don't want to delay the treatment, and you want to start the treatment as soon as possible. So not to ignore the symptoms. As a person gets more symptomatic, the outcome worsens. And if someone comes in with very advanced disease and have not sought medical attention on time, bladder cancer's outcome without treatment is about 4 months on average. So not to ignore the symptoms that you don't understand why you have them. Simple, basic thing to do is speak with your primary doctor, and they'll start with labs, and that will guide them what's the next step. Coming back to treatment, so chemotherapy is delivered before surgery for muscle involving bladder cancer. Beyond that, past that, we basically treat stage 4 bladder cancers. Until recently, I think 2017, all we had was 2 chemotherapy regimens, and they did work, but average survival of stage 4 bladder cancer is still limited. But over the last 3 years, the field of medical oncology has made a lot of progress, and we have at least 3 immunotherapy drugs approved by FDA. There are 2 targeted drugs. One of them is an oral medicine that can be used if the patient's tumor has what's called FGFR3 mutation, and some people do amazingly well. Immunotherapies, as I mentioned earlier, are extremely easy to take, and some of the patients have very long life. They have a durable response, we call it. Immunotherapies are so easy to take. Many times patients are continuing with their life. They're going to work. Most common side effects are rash and diarrhea and fatigue and some thyroid issues, but you don't see that too often. Those side effects do begin to come up as someone's gone past several months or maybe a year or two, but it's very easily tolerated, well tolerated drug, and the mechanism is very natural. What immunotherapy does, it stimulates the person's immune system, and then the immune system fights the cancer. So it's kind of, if you want to call it, a natural mechanism. FGFR mutation therapy is easy to take. It's an oral regimen. It's pills you're taking, and in the beginning you go to doctor more often, but later on, once a month, just labs and discussion of the benefits and side effects. And the other treatment is an IV treatment, and it's also something we call targeted therapy. So bladder cancer treatment in the last 3 years, in summary, what I'm trying to get at is has improved, and I believe that medical oncology is at the beginning of a new era where treatments would be totally targeted based on either DNA mutation or immune system. And it's very possible at some time in future we're going to see chemotherapy as barbaric treatments. So that good time is coming. There are many new receptors that we know of that are seen in bladder cancer that are being targeted in clinical trials. And there's even a vaccine that's being looked at. I think good times are coming in terms of treatment of bladder cancer. I always tell everybody that, of course, prevention is the best strategy, having a healthy lifestyle. And that really comes down to three basic things. Assuming that you're not smoking and not drinking heavy. It comes down to three things: that you eat well, sleep well, and exercise. In eating well, basically, we just talk about eating fruits and vegetables and try to eat organic and try to not eat processed food. We also discourage refined sugar. I believe that sugar in fruits and vegetables are just fine. Some people go to the extreme of avoiding fruits with carbs, but I think that's a little bit unreasonable. In terms of exercise, just brisk walk, 30, 40 minutes a day, 5 days a week should be adequate. I believe that sleep is very much of an ignored health strategy. Adequate sleep, 7 to 8 hours per night, deep sleep is extremely important. That's when the melatonin is secreted and the CSF, the fluid inside the brain, washes away the harmful proteins and other substances. So a deep night, 7 to 8 hours sleep, regular exercise, and eating well. Of course, not smoking and heavy drinking. And that's, we are going to have something, but your chances of getting illnesses are lower if you adapt this strategy. And that's pretty much all I have to say. That keep the hopes alive, and please ask if you have any questions.
Dr. Syed, we had a listener send us a message. They are a smoker and have been diagnosed with bladder cancer and are having a hard time quitting. What kind of advice do you give patients who smoke and understand that it's not good for them for various reasons and want to stop but just can't do it on their own? What's the solution?
Yeah, so I do prescribe some medications, but I primarily advise them to talk to the primary doctor because the medications prescribed for to help people quit smoking can have some side effects. So a very close follow up is required, and when they come to us, we manage them too. But yeah, there's therapy. Psychotherapy, if you want to call it, hypnosis. All of these strategies have their own benefits and um, success rate. But I think most commonly adapted strategy we use here is to prescribe either Zyban or Chantix. But you have to really screen the patient well because they come with their own side effects. In my experience, the most important thing has been that the patient needs to be motivated. And if the patient is motivated, they're going to succeed. It is important to note that on average, it takes about 3 to 5 attempts to quit smoking. So if someone tries to quit smoking and they fail, they don't need to give up because that's pretty normal. Keep on trying because there's a very good chance they're going to be able to quit smoking.
Another listener had inquired about naturopathic remedies for bladder cancer, and maybe you can comment if there are available in addition to what the standard treatment regimens are, or could you comment on if it excludes standard treatment regimens? How would you counsel this particular listener?
Yeah. Yeah, so I believe, and the literature shows that lifestyle is good for prevention of cancers. But once the cancer occurs, if you think about cancer, it's a DNA level disease. When the DNA level change has occurred, it's really difficult to change things with lifestyle alone. So I tell patients to, as I mentioned earlier, eat well, exercise, and all that stuff. But uh, there's not any evidence that we know in our field, and of course, we're not experts of those herbal medications. Um, so generally, actually, we advise patients not to take any herbs while they're on chemotherapy or other treatments because there is interaction between and those herbs and the chemicals and in our treatments. In fact, we even advise our patients not to have tea or green tea on the day of and maybe a day before and a day after chemotherapy uh, because it may change how the drug is going to work. I take turmeric, and I have a lot of friends who are taking it, so they have a lot of benefit from it. But I recently came across an article that if someone's taking taxane, which is a chemotherapy, and they're taking turmeric, it may affect the metabolism of the drugs from the liver. So I think while we don't really know how these combinations work, it's best to stick with one mode of therapy while you're going through treatment. Now, in terms of vitamins and supplements, if you want to do those, you want to do those once you're done with all our treatments, and then you can go on. Studies don't show any benefit of supplements. In fact, studies show that men who were smoker had actually harmful effects from too much supplementation for unclear reasons. Women did not, and non-smokers not as much. Um, so it's not just that when you're taking supplements, there's no impact of that on the body. So I think we have to be careful taking herbs and supplements, but especially when you're taking them while you're on treatment, it's something we advise against. Um, it's I have looked into the reasoning. One reason I found that, for example, green tea has a lot of antioxidant, and it protects the cells from oxidative injury. So question is, and we don't have an answer, does consuming that product help the cancer cell as well from the oxidative damage? It's what I have come across in terms of literature, that it's going to be very unethical to run a trial like that and give somebody something when you don't know the outcome. That it may harm their condition and worsen their condition. So again, I think I want to summarize this way that if you want to do supplements, try to avoid doing that during the treatments. I think it's a good idea to discuss that with your doctor and not to hide from doctor. A lot of people in community want to take supplements. There's a study that showed a good percentage of patients are taking supplements, but they're not telling their oncologist, and that can have some harmful effects because not every supplement is benign. So be open to your doctor and let them know. And I can tell you, most of the times they'll advise not to do that. Yes, when you're done with the treatment, sure. But again, we are not pro supplements. We are pro fruits and vegetables, fresh, organic food, and not very much processed and not with very much, refined sugar in it. I don't know if it answers the question.
Yeah, that was very helpful, and I think we have just one final question, and this relates to the risk versus benefit of the scans and the radiation involved with scans for detection and monitoring of bladder cancer, and kind of a corollary. Many of these treatments can have bad side effects in themselves, and so the concern from the listener was, well, don't these other treatments, whether it be radiation for monitoring or imaging that has radiation for monitoring, or treatments that have harmful side effects, why are they used in this situation?
Yeah, so that's not an uncommon concern. I remember a long time ago there was a study that looked into it, and what I recall that the conclusion was that 1% of all cancers were caused by therapeutic exposure to radiation. But what was interesting is when this was looked at in detail, what they found that majority of those cases were when um, kids were diagnosed with cancer at a very early age. So they had a long life of 30, 40, 50 years of scans and surveillance studies and exposure to radiation and stuff at a young age, where DNA was fragile and vulnerable, prone to get hurt easily. So it was that, and so it's not a huge concern for us. In many situations, the exposure is not that high. Like, for example, the screening CT that smokers, if they meet a certain criteria, they have once a year. It's 1/5 of the standard radiation from CT, normal CT diagnostic, and it has no contrast. So that's just a small argument. And besides that, the benefit of having imaging studies for a good reason outweigh the risks. There was some few years ago, there was a study that showed that some of the places, and I recall that England was one country where there's rationing of the healthcare. The cancers were diagnosed somewhat later than in the United States. So I think we do a lot of imaging, but we find a lot of early cancers, and we end up curing them. Majority of the masses that we find, we call them incidentalomas. Patient goes to ER after being involved in an accident, and a CAT scan of the entire body is done, and you incidentally find a mass, and you go to a surgeon, get it taken care of. And as I said earlier, the key is to find things early. Now, that is not to say everybody should have imaging irrespective of their risk. I think our healthcare system in my 20 years has improved in the sense that we now, if we don't want to, we really have to look at the reasoning behind why I'm ordering a scan. And I think it's a good thing and to have that kind of surveillance. But I think we've gotten better. I don't think we order scans for no reason. Our primary care doctors in town, everybody I work with, they're very intelligent, and they order these scans very appropriately. Sometimes it feels like it's not needed, but then the information we gain out of those imaging studies are vital for make the difference of life and death. So going back to the question, yeah, you don't want to do the scan when it's not needed, but when it's needed, it saves lives.
Thank you very much, and thank you for listeners for your contributions, and we hope we're making an impact in our community. We look forward to having you join us again in January, so enjoy the holidays, and we will have another meeting of the Bladder and Prostate Cancer Support Group in January. Thank you very much again, Dr. Syed, for your wisdom and your care, and we look forward to working with you in the future.